and Sara McElroy to talk to us today about the situation with dermatology and what we need to be aware of. I'd like to let her give her presentation as she does, and at the end, then we'll finish up with some questions and answers. And if there are any leftover lunches at the end, you all please feel free to help yourselves in seconds. And Janet, you came in late. There's a veggie one over there. I know you're a vegetarian, so you please. Well, then there's a regular wrap over there if you'd like. But anyway, thank you all for coming, and we do appreciate it. And I'll turn it over this time to Sara.
Awesome. Thank you very much. All right. Hello, everyone. My name is Sara McElroy. I am working right now at the Moffitt Cancer Center Southshore location, so just down the street. And today I'm going to be teaching you a little bit about sun safety and skin cancer and what some of these lesions or abnormal moles may look like, so that you're able to hopefully identify them and get in to see dermatology if a biopsy is needed or something like that. So a little bit about my role at Moffitt. I do medical oncology, so this is someone that has already been diagnosed with a skin cancer. Typically they've seen a surgeon and potentially even a radiation doctor. Now, if they believe that some sort of systemic therapy or something like chemotherapy, immunotherapy, or targeted therapy, which are pills, if they think that that's something that a person would benefit from, they'll meet with a medical oncologist and like someone like me that I work underneath, and we will talk about those treatments and get that patient taken care of. Okay? All right. So really important to do presentations like this today because you don't want to see a medical oncologist. Skin cancers can be easily treated and cured if caught early. And so teaching you how to avoid risk factors and also identify these when they're very small may prevent future headaches.
Be sun safe.
All right. So rule number 1, be sun safe. So about 95% of melanomas are caused by ultraviolet light or ultraviolet radiation. And so staying out of the sun, or if you're in the sun, wearing protective clothing and sunscreen is the most important thing. We're going to go into that in a lot more detail today. All right. So throughout this presentation, my goal is for you to learn about the risk factors, learn a little bit more about UV exposure, sun safety, and then at the end we'll go through what some of these skin cancers look like and give you a little acronym for you to remember when you're looking out for melanomas. All right, so the risk factors for skin cancer in general are what you would think, right? Light-colored hair, light-colored skin, light-colored eyes. Everyone has the same number of melanocytes, which are cells that produce melanin, which melanin is the pigment in your skin that protects you against UV radiation. Everyone has the same number of those. It doesn't matter how dark or light your skin is. Now, the difference is how much melanin those melanocytes produce. And so people that have darker skin tend to produce much more melanin, or that protective factor, than someone that has very light colored skin. The people that are at the most risk, or the people that produce the least amount of melanin, tend to be blonde or red-haired people that freckle really easily, or they always burn when they're out in the sun. As we go to the next slide, we'll see the Fitzpatrick score, which is what we use to help categorize at-risk patients. So some of you may have heard of Moffitt's Mole Patrol, but this is a group of people, a group of volunteers that go out to different community events. A lot of times they're linked up with like a large sporting event or a race, like a cancer benefit race. And there's always one dermatologist at least Typically, there's also a physician, either a surgeon or a medical oncologist, and then nurse practitioners, PAs, and people can get screened for free. A lot of people go because of insurance issues. Some people, they're religious about seeing their dermatologist and they just want another set of eyes. But that's a great opportunity if you have a hard time getting in to see your dermatologist, for someone that's very skilled at looking at different skin lesions to take a look. But when we do these screenings, we ask people, are you someone that always burns or never burns? Do you tan easily? Do you not tan easily? And that kind of helps us decide how at risk they are, how often they should be seeing a dermatologist, and things to look out for when we're trying to provide education. All right. So a little bit about how the sun damages our skin. So on this picture, you can see UVB and UVA rays. So UVB rays are absorbed in this top layer of the skin called the epidermis. UVB rays are what cause sunburns. UVA rays, this is about 95% of the sun rays. Those are actually absorbed in the middle layer here, the dermis. Damage from UVA rays tends to cause more age-related changes, so wrinkles, sagging skin. You can see some of the hyperpigmentation or age spots come from that UVA. A little bit later, we're going to be talking about sunscreen. And this slide is important in reference to how sunscreens work and what they're protecting you against. All UV rays can cause damage to the cell's DNA. It's damage to that DNA that can cause mutations and cancer down the line. All right, so skin cancer. I've got some pictures here. 4 of these are true skin cancers. 2 of these are pre-skin cancers, or can be precursors to skin cancer. Melanoma, up in the right-hand corner, this is the majority of patients that I see that require some sort of immunotherapy or chemotherapy or targeted therapy. So melanoma, we're going to go through an acronym at the end to give you some advice on what to look for. It's the A, B, C, D, E's of melanoma. But these are typically moles that look somewhat abnormal from a regular mole. They're a little pigmented, or they change in the color. They tend to color outside the lines, so they're not a nice perfect circle. And for a patient that has melanoma, when they see a dermatologist will usually do a punch biopsy, which is a biopsy that goes a little deeper, and they'll be looking to see if there's multiple layers of the skin that are involved. If there is, when they see a surgical oncologist or a cancer surgeon, they'll look to see if there's concern for nearby lymph nodes, like underneath the arms, in the groin, on the neck, to see how involved that melanoma is. If there's signs of distant spread or even little tiny melanomas nearby, they'll typically refer to a medical oncologist to talk about using immunotherapy either before surgery or after surgery. Basal cell carcinomas, that second picture up there, those tend to be described as pearly and pink. If you look really close at a basal cell carcinoma, you may see tiny little blood vessels in it. These very rarely metastasize, so they tend to be a less concerning finding, but they should still be addressed because they are still considered a cancer. And these tend to come from very intense early childhood sunburns. Squamous cell carcinoma and actinic keratoses, these two go together. Actinic keratoses is the precursor to squamous cell carcinoma. So these tend to feel scaly and rough. A lot of times people might develop them on the tops of their ears or on their scalp. These are from more chronic lifetime exposure to the sun. These can metastasize. They can also travel along nerves, which can cause pain. And so it's important to get these addressed. A lot of times an actinic keratoses will be treated with freezing, like liquid nitrogen, or a topical chemo cream. A squamous cell carcinoma may be treated with a Mohs procedure, where they go layer by layer to make sure that they've gotten all of those cancer cells removed. I see a lot of fishermen and golfers that tend to develop these squamous cells. An atypical mole may develop into a melanoma, but not necessarily. So these are moles sometimes on the pathology report. They'll be reported as a dysplastic nevi with a mild degree of atypia or a moderate degree of atypia. Those tend to be less concerning than severe atypia or melanoma in situ. That's when we have to, make sure that it's fully removed and thoroughly treated. Okay. Merkel cell carcinoma, this is the most rare. This was a skin cancer that a lot of people had never heard of until Jimmy Buffett passed away. This is the type of cancer that Jimmy Buffett passed away from. But about 20% of Merkel cell carcinomas are caused by sun exposure, and they tend to look more like a bug bite, but they change very quickly. So men are more at risk of this. Anyone that's immunocompromised, so someone that has to take prednisone or other immunosuppression drugs because of maybe a history of an organ transplant or autoimmune disease that requires some immunosuppression. Immunosuppression in general makes all of these slightly more difficult to treat, so even more important that those patients are getting seen regularly by a dermatologist. All right, so this brings us to sun protection, some of our recommendations for preventing sunburns and UV damage in the first place. So seeking shade, especially during the midday hours, usually about 10 to 2, 10 to 4, trying to be really careful if you're in the sun, that you're wearing adequate protection and sunscreen. Wearing sun protective clothing that cover your shoulders, arms, legs, neck, again, top of the ears. This is a place that's very commonly forgotten. So that's very important. When you think about clothing, a white cotton t-shirt is only going to provide about SPF 5 to 10. The SPF stands for sun protective factor. So if you're using SPF 50, it means you could stay out in the sun 50 times longer before you would burn, okay? Most sunscreen protects you against UVB rays, which was that top layer that causes sunscreen or sunburns. UVA rays is that dermis level, the one that causes the skin sagging or wrinkles. If you get a sunscreen that has broad spectrum, it means it covers for both, okay? A lot of people have questions as far as what's safe, what's the best sunscreen. In terms of safety, the mineral sunscreens with zinc and titanium, those really, really greasy, white, thick sunscreens do tend to be the safest, but there has not been conclusive data to say that the chemical sunscreens, even some of those ingredients that have been listed as you should watch for these, even those haven't shown conclusive evidence of cancer. So the best sunscreen is the sunscreen that you wear, okay? You want to be reapplying every hour and a half to 2 hours, even more often if you're getting wet, like swimming. Wearing wide wraparound sunglasses so that you're able to protect the corners of your eyes. A wide brimmed hat is going to protect the tops of your ears and your nose. And then again, applying at least SPF 50 routinely. The FDA is actually kind of guiding companies not to mark it above SPF 50 just because at that point it's pretty negligible if you're getting increased protection. And so SPF 50 is plenty. Okay. All right. Also, don't forget wearing a lip balm that has some SPF component to it. Another place that we do sometimes see melanomas develop, and that can be a difficult place to do surgery on, as I'm sure you can imagine. Chemical sunscreens, so the non-zinc sunscreens, those do need to activate. So you want to apply those 15 to 30 minutes before you actually go outside in the sun to give those time to actually start working. All right, and then here's some more specifics on clothing to look for. You can look at tags and labels to see what they are marketing their protection as. Darker colored clothes offer more sun protection than a lighter colored clothing. Something that's a synthetic fabric is going to offer more protection than cotton, for example. The denser the weave of the clothing also helps. And then if clothing is wet, it is not as protective. So like a wet white cotton t-shirt is not actually going to give you much protection at all versus something that's dry and long sleeve. I like the fishing long sleeved with the hood on the back just because it's a nice way of protecting the back of the neck. All right, so then a little bit about detection or looking out for abnormal moles or lesions. One of the things that's really important to keep in mind is something that doesn't heal. Even if it looks like a bug bite or a wound, really within a few weeks, that should be starting to make progress. If not, you should really have an expert take a look and make sure that a biopsy isn't needed. That's the best way for anyone to say definitively what's going on there. You can have cancers develop in the site of a chronic wound. That can happen. So this goes through just some FYIs for skin exams. We say about every month. If you're someone that has a lot of different spots and you're not really sure, I always recommend taking pictures. That way you've got them on your phone, you can show them to a dermatologist, hey, this is what it looked like a month ago, this is what it looks like now. In fact, some dermatologists, if a patient comes in and they've got maybe hundreds of moles, they may recommend total body photography where the dermatologist actually maps out those moles and is able to monitor them that way. Also, when you're doing those skin exams, you should be feeling for any lumps or bumps in the lymph nodes. Tend to feel like a hard olive-shaped mass. And then this is the ABCDEs of melanoma. And so when we're screening for this, we're looking for a mole that is asymmetric, meaning if you were to take it and cut it in half, it would not look like a mirror of itself. It would be kind of squiggly on one side and maybe a nice circle on the other. The border, uneven borders. So again, this is that coloring outside of the lines looking appearance. Color, there's a variety of different colors all in one single mole or lesion. Maybe red and black and brown, or it started one color and now it's sort of a different color. Diameter larger than a pencil eraser is a rule of thumb. And then evolution, it's changing over time. Now, there are skin lesions that fall into this category that are completely benign. A lot of people will have something called a seborrheic keratoses, which looks like a stuck-on waxy brown lesion. You might have a red mole. A lot of women will get them on their chest. Those are called cherry angiomas. Those are benign. But as a general, this is what we're looking out for when we're doing those skin screenings. I've also heard it described as look for the ugly duckling, the spot that doesn't look like the rest of the moles. That's the one that you should really hone in on. A dermatologist will use something called a dermoscope, which is like a microscope with a light on it, and they'll hold it up to your skin as they're doing their exam. That way they can look for tiny things like the little blood vessels I was talking about that we can see in a basal cell, or they'll be able to look, is there a hair follicle within this lesion, or different things that might make it look more suspicious or less suspicious. And that's all I've got. I'm ready for questions if anyone has them.
Is it true to say that basal cell is actually a precancerous condition, or is it actually cancer?
So the question is basal cell a precancerous or a true cancer? It is a true cancerous lesion.
That's typically removed with,
Yes, usually a dermatologist is able to remove that in office, and you go with on your life.
Question. I've had 3 sites for Mohs surgery because of squamous cells. I'm not sure who told it. Could have been a PA, could have been a doctor. But I was under the understanding that if a skin or a body has suffered high impact damage, normal cells can mutate to squamous cells.
So the question is, can normal cells mutate to squamous cells because of damage, like trauma?
Right.
It's probably a combination of multiple factors. Trauma can be one of the predisposition, like a chronic wound, right? We've seen squamous cells develop in people that have, for example, spina bifida and a pressure ulcer from that has never healed, or certain types of skin conditions. But it's more likely, especially if it's on the scalp, more likely related to DNA damage from ultraviolet radiation or sun exposure.
Well, basically sun.
Yes. Yes, go ahead.
Is it true that Jimmy Buffett died from cancer, from skin cancer that got under his toenail?
So that's actually Bob Marley. I'm glad you're bringing this up. So the question is, did Jimmy Buffett die of a skin cancer from underneath the toenail? So Jimmy Buffett died of Merkel cell carcinoma, but Bob Marley, the Jamaican reggae singer, died of melanoma, even though he has a darker complected skin tone. He died of something called acral melanoma, which is melanoma that starts underneath the nail. And so it's really important when doing skin screenings to be looking for, like when you slam your hand in a door and you get that black bruise or hematoma underneath the nail. A melanoma can look like that, especially in a darker complected individual. And what makes it suspicious versus not suspicious is, 1, there was no trauma that develops before the melanoma. 2, when it passes over the cuticle, that tends to be a red flag. And so when you're doing your own skin exams or when you're seeing the dermatologist, they should be looking at the nails of the fingers, toes, and then also in between the skin, the webbing of the skin in between the fingers and toes, looking for anything abnormal there.
How about sunglasses? I know you buy them with UV protection, but is there any special sunglasses we should look for that have a better protection than UV?
Not that I'm aware of as far as the best sunglasses to purchase, but something that does actually cover the corner of the eye tends to be better, because when you're thinking about applying sunscreen, you want to be thinking about areas that are more difficult to actually get adequate coverage. So around the eyes in general tends to be a little bit more difficult to layer that on.
I'm hoping this is a stupid question. If you go for walks early in the morning and you get home just as the sun is hitting the ground, should you feel safe?
So great question. When should you wear sunscreen? When do you not need to wear sunscreen? So typically, if you're one of those Fitzpatrick 1 or 2, those very, very light skin tone, you freckle really easily, you burn really easily, you really should be wearing sunscreen all the time, even if it's not very bright out or if it's cloudy out. The UV index can be a nice guide. They say around 3 or lower, you may not need sunscreen. On a day like today, the UV index, I checked it before I came in, it was 7. So 3 or below, you're probably okay. Again, the evening hours, usually the UV index drops off quite a bit. So probably okay. But a good habit to get into just first thing in the morning after you brush your teeth is to apply some sort of sunscreen.
I'm saying actually before the sun is up.
Yeah, then I would say you're okay. Yeah.
This cancer that you cited, where it's actually in the bed of the nail.
Mm-hmm.
First of all, how do you diagnose that if it's under the nail? Secondly, how do you treat it?
Yes. So acral melanoma, the melanoma that starts underneath the nail bed, they will actually do a nail biopsy. It's typically certain surgeons will do that. I don't know if a lot of local dermatologists will do that or not, but if there's a suspicion, they will absolutely need to biopsy that. How you treat it depends on how it has spread. So if it's very localized, sometimes they'll recommend someone do immunotherapy first and then potentially an amputation of that finger. Sometimes they'll say, let's do immunotherapy and look for other lymph nodes. So it depends. It's very patient specific, but a lot of times it involves completely removing, at least the up to the very first knuckle of an amputation to make sure it's completely gone. Yes, go ahead.
You know one of them machines that you see on TV that they X-ray instead of cutting your face?
To do like a radiation, essentially? Yes, so sometimes they will do radiation. Moffitt is like an alternative to doing cryotherapy or the liquid nitrogen. We don't do that, but we will use radiation if they have done surgery and there's concern that there might be little microscopic cells left behind, or they haven't gotten what they call clear margins, which means clear margins means we got all of it. If there's some disease left behind, sometimes they'll use radiation to essentially sterilize the field and try to get any of those tiny little cells taken care of.
Can you go to Moffitt just for a checkup, or you have to have some kind of cancer?
Yes, so Moffitt wants you to have some workup already completed. We do have dermatologists at Moffitt, but they tend to focus more on either patients that have a history of melanoma or patients that have developed some sort of skin side effect from a treatment that they were on, either from the cutaneous or the skin cancer department or another department. So typically they'll actually recommend patients go to USF for routine skin exams or their local dermatologist and start there just because it's easier to be seen every few months, and then come to the Moffitt team if there's a problem that requires, we call it multidisciplinary, but multiple specialists like a surgeon, a radiation doctor, a medical oncologist. Go ahead.
You mentioned clouds. I was under the impression that clouds don't stop the UV rays.
Right, exactly. So that can be a false sense of security. If it's a really cloudy day, you definitely still need to be applying the sun protection. Yes, go ahead.
I have what the doctor says is a cyst on the top of my head. Do they ever turn cancerous? Something I should watch.
So a cyst is very common. A lot of people will have cysts. The dermatologists are pretty skilled at saying what looks suspicious, what doesn't. If they're questioning it, they may want to do a biopsy to confirm, but it's not an uncommon finding to have a benign cyst. Mm-hmm.
You mentioned Moffitt does not do the cryo. Is that the same as freeze drying?
The cryotherapy our dermatologists will do, but you can do as an alternative to cryotherapy. There are different types of radiation that can be used. I do not believe our team does that type of radiation for pre-skin cancers.
So, you just go into a dermatologist for regular checkups just to see if you're okay. They do a lot of the freeze drying.
Yes.
And that is what you're talking about?
The Moffitt team, yes, does do cryo.
Is there a reason why you don't recommend the regular dermatologist to do that?
No, the regular dermatologist absolutely can do cryotherapy. It's a very good way of treating those actinic keratoses while they're at an early stage and preventing them from becoming a squamous cell. Yes, you in the back.
Tell me about the genetic studies. I had a genetic study done after I had melanoma.
Yes, that's a great Yes, so genetic studies can be done on melanomas. There's something called next generation sequencing, where they look at the genetics of the tumor itself, not the whole family's genetics. And what they're looking for is mutations in the cells that can essentially point us to what went wrong, and is there a pathway that these cancer cells are using that we could maybe turn off with targeted therapy, or personalized medicine is another term that you'll hear. So about half of melanomas have a mutation called a BRAF mutation. And if we find that they have this BRAF mutation, we can use pills, or it could be considered to use pills at some point if we needed them, to turn off that pathway and hopefully prevent the spread or any cells that are too tiny to be picked up on a scan, to try to turn that pathway off. Even in those patients, though, it's important to remember that cancer can be tricky and it can evolve. And so even with our targeted therapies, they can work for a set number of time. Everyone's a little different, but there may come a point where that melanoma outsmarts us. So we tend to use a lot more immunotherapy, even in patients that have that BRAF mutation.
So would you recommend, mine came back that there was no chance of me having a recurrence, but how accurate is that?
It depends. If they have clear margins and it's an early stage, you would just live your life and do your normal skin exams every 6 months to a year. Everyone in Florida should be seeing a dermatologist every 6 months to a year, just because we're living in a tropical place. But there's never any guarantee that someone could say there's no way this would ever come back, especially in someone that's already had a melanoma. Yeah.
I had the blue light therapy, and it scared me because for 20 minutes you burn. But it did bring up some plastic stuff coming out of my skin. But I still go looking, because underneath all that, it could be another one underneath it.
Yeah, so blue light therapy is a treatment that some dermatologists will recommend to try to reverse some of the photo damage caused by the UV rays. And so I've seen our dermatologists recommend that for some patients. I've also seen them try to use that for some very persistent rashes. So it's a lot of time for those treatments, but I have seen that recommended in the past. Go ahead.
Since we're recommended to use sunscreen, seems like use quite a bit of it. How does that interfere with vitamin D?
With vitamin D absorption? Yes, so most vitamin D does come from the sun, and so if you're never in the sun, you're at a greater likelihood to develop a deficiency. Vitamin D can be replaced orally, so if you're very, very careful about wearing your sun protection, your primary care doctor is probably checking a vitamin D level annually, maybe more often if you're someone deficient, and recommending supplements if needed. And so typically if you're someone that's deficient and you're not absorbing adequate vitamin D, then you can take a pill, sometimes weekly, sometimes nightly, to help replace those stores. Mm-hmm. I'll go with you and then, okay, go ahead.
Yeah, Australia's years ago changed over from a certain suntan lotion that killed coral to one that didn't. Is there a sun lotion or screen that you would recommend here that you can buy that doesn't kill coral, but also gives you adequate protection?
So looking for broad spectrum, SPF 50 and reef safe is the non-coral killing. The brand is not specific. If it meets those criteria, then yes, it's a good sunscreen. I don't have like a specific, copper tone's better than, a different brand or anything like that. if you're very cautious or you prefer something as holistic as possible, those zinc sunscreens that have that white cast, those are the safest sunscreen to use. But again, it's best to use any sunscreen. There's never been a definitive link to cancer-causing ingredients there. When they have looked into some of the studies done, there's some ingredients that tend to be a byproduct of poor manufacturing that they've tried to kind of eliminate. But wearing sunscreen in general is better than not wearing it because you're worried about the ingredients.
I have a benign melanoma on the side of my face. What is that really called?
It could be a seborrheic keratosis, those waxy mole, brown looking, seborrheic keratosis. Sometimes they'll call them a wisdom spot or an age spot. Mm-hmm. Yes. Very, very, very common. Probably one of the things that dermatologists see the most often. Yes. What was that?
The sun cream, does it get old?
I believe there is an expiration date. If you look on the bottle, you'll see a tiny, tiny little picture that looks like a little cream thing with a lid open, and it'll have like a 6 in there or something else like that, and that'll say once you've opened it, it's good for 6 months or something like that. So look for that tiny little picture, usually underneath the ingredient list. Yes.
Is there any visual difference between an actual bruise on your nail and the nail bed, or is it cancer in the nail bed?
So if it's a bruise, most of the time people remember the injury that caused the bruise. If it's growing out as the nail grows, less concerning. If it crosses over that cuticle, that's when we say, this is a more high-risk lesion. Again, acral melanomas are quite rare. Usually it's a result of trauma from something, but something to keep in mind if there's a spot underneath the nail that's not going away and not growing out.
Could that be caused by tight shoes?
That sounds more like a trauma.
Okay.
Yeah.
So it's probably just a bruise.
Probably just a bruise.
So you said seborrhea, right? Seborrhea keratosis.
Yes.
Then I must be brilliant. Because I've had them everywhere. Putting on my scalp and then
They're very
gotta
common.
get the Freon.
All right. Any other questions? All right. Thank you all so much. Thank you.
Sarah, thank you ever so much. And Jeanette, please stand, dear, if you could, because if it weren't for Jeanette, we wouldn't have had Sarah here today. And Jeanette coordinates all of the folks from Moffitt that come and speak to us, and we thank you so much for that. And thank you for coming. Wonderful presentation. Thank you all ever so much for coming.